We need them in French though, so hang on one sec. You know what, ask Amanda. Ask Amanda first. She was standing right in the hall. Yeah. Okay, I think we have them in French. Yeah, excellent. Good morning. We're starting a little bit later. We're hoping we'll have a couple more people trickle in. So welcome to our community forum. The community forum is planned by the American Academy of Cerebral Palsy and Developmental Medicine by our community council. The community council is a small but mighty group of individuals with lived experience. We may be parents of children and youth and adults with cerebral palsy or individuals with cerebral palsy. Our group has members in both the USA and Canada who take part in advocacy within our communities. Many of us also work in the field of disabilities as occupational therapists, recreational therapists, physicians, and nurses. As the current chair of the Community Council, I welcome you to the day we have planned. We're extremely thankful to the amazing lineup of speakers we have planned for you. These clinicians have dedicated their practice to those with cerebral palsy and share an innate knowledge in how to improve the lives of those with cerebral palsy. As a parent of a 19-year-old with cerebral palsy who is attending her first year at university, the knowledge and relationships I've gained during my time with the Academy is immeasurable. We look at the Community Forum as a gift to those with lived experience from the American Academy. The Community Forum is planned over the span of a year by the Community Council members. We discuss topics we as parents and individuals with cerebral palsy find challenging and we want to learn more about, or maybe it's hot off the press, such as new research. We also use the feedback that you as participants provide us with our future planning. Throughout the day, members of the Community Council will be here. Please feel free to chat with us over the breaks or come to us with any questions that you may have over the day. Can our Community Council members just wave? So any time in the day, just feel free to come and ask us any questions. You'll be asked after each session to provide your feedback, and your feedback helps us to plan for a successful event next year. And then please visit our website. The American Academy has our Community Council webpage, and you can watch all the previous sessions that we've had over the past couple years. And in a couple months, we're a little slow because we are volunteers, but we will get today's forum as well on our website. And I will introduce our next speaker, Jen.
Hello. I am here to introduce sleep struggles and cerebral palsy with Dr. Golda Milo-Manson. And Dr. Milo-Manson is the Vice President of Medicine and Academic Affairs at Holland Bloorview Kids Rehabilitation Hospital, a role that she's held for 20 years. She's also an associate professor in the Department of Pediatrics at University of Toronto. She has worked in pediatric rehabilitation for more than 20 years, largely with children and youth with physical disabilities as well as complex sleep disorders. And she's been a member of the American Academy of Cerebral Palsy and Developmental Medicine for most of her academic career and is currently serving on the executive board of directors. And she served as the local co-host for 2 AAC PDM meetings here in Toronto. I saw a similar version of this presentation for Academy members last year, and I knew that I had to ask her here for families as a parent who's got a son with sleep struggles. This was a really, really impressive and very helpful presentation. So welcome, Golda. Thank you so much for being here.
Thank you so much, Jennifer. Can you guys hear me okay? Yeah? Okay. It's a small group, so those in the back rows, feel free to also move closer. And because I am on the board, I'd also, my role as secretary, but I really, on behalf of the board, I'd also like to welcome you here. What a beautiful city. I mean, I have been here before because I am Canadian and we know this is a jewel. But really, on behalf of the board, thank you for hosting us and for welcoming us to Quebec City. So as Jennifer said, I'm going to share this presentation on sleep struggles. I've been at this a long time, working with children and families at Hull and Bloorview. Although it's not an official sleep clinic, there is rarely a patient I come across who doesn't have some question or concerns around sleep. No disclosures. So really what I'm hoping to do is share the evidence around management of sleep problems in children with CP, talk about some treatment options, and then really talk about some contributing factors, and if possible, can we prevent them by setting some good practices in place before they happen. So there are many types of sleep problems. Insomnia is difficulty falling asleep, one of the more common ones, particularly at younger ages. Night awakenings, waking up throughout the night. Parasomnias is kind of the official term for a group of disorders, things like nightmares, night terrors, sleepwalking, rhythmic movement disorders. We are not going to have the time, or will we be talking about most of these. We'll focus more on insomnia and night awakenings, but I think it's really important that you know that there is a huge spectrum out there, and that they can also impact sleep. Phase shift is when, particularly we see in some of our children who have cortical visual impairment where their days and nights are mixed up. And then seizures, for those of you who may have children with epilepsy, it is probably no surprise that particularly nocturnal seizures are very impactful and disruptive to sleep. This looks quite official, but I think when you take a look, it'll kind of help you understand what happens. So, can you see my cursor? I don't know if it's working. Anyways, I'm going to jump up and hopefully you can hear me. At the top, the gray bars, that is actually when the child falls asleep. And similar for you and I, when we fall asleep. And then, thank you. Oh, is that better? And then you fall into a deep sleep, and we kind of cycle every hour to hour and a half through that. What ends up happening, though, and what I want to bring your attention to is the red bars. That's REM sleep. And you'll see as you first fall asleep, there aren't a lot of REM bars. But as you get closer to waking up in the morning, the bars become a little wider, and also they're closer together. And, you know, if you think about it, now not everybody does this, but some people, say, oh, I had a bad dream, or I had a really nice dream, and you remember that dream, and that's because it's happening closest to when you wake up in the morning, as opposed to happening when you first fall asleep. And we'll come back, we won't be, this isn't to understand sleep problems. You don't have to remember this, but I will try to tie it, and you'll understand why certain things happen at certain times. I don't usually get up and move around like this. So really, why do sleep problems happen in children with cerebral palsy? A lot of the literature isn't specific to CP. Sometimes you'll see when in the presentation some is. Some, in fact, is more talks about neurodevelopmental disorders in general, because there are many similarities. And you'll see that I even bring in a few things from some of the literature around sleep problems in children with autism, because I think it's very helpful and things that can be very easily adapted. So sleep problems, obviously, I don't think to anybody who has a child with CP, know that if a child doesn't have a good night, even typically developing children, if the child, for whatever, has a bad night, if I have a bad night, I'm not as doing my best or functioning at my best the next day. We know that anybody who doesn't have a good night's sleep, things happen to be more stressful the next day. And we know that in our children who have CP, neurodevelopmental disorders, that sleep problems, depending on which literature you look at, can happen anywhere from about 50% up to about 85%, 95% of the time, again, depending on whose study you look at. So really, why are they more common? Many, many reasons. This is just some, but they can arise from a primary dysfunction, sleep disordered breathing. For our children who, particularly the prems, who may have had a lot trached, vented, a lot of time in the NICU, tracheomalacia, so some tracheal problems, those can also predispose. There is something called circadian rhythm disturbances. These patterns of sleep are much more challenging in children who are visually impaired and do not visually track. And we also know those children may not pick up on the external cues in the environment that, we know when the clocks change and it gets dark so early, I have a harder time staying up as late as I would in the summertime when it doesn't get dark until 9:30, 10 o'clock at night. And then there are chromosomal abnormalities that actually, or brain malformations, that have increased wakefulness and poor progression through the sleep stages. And some of those have to do with the way the brain is laid down in utero. There's a schizencephaly is one particular pattern, and those children with the way the brain is laid down early on are very prone to sleep difficulties. We know that children with intellectual disabilities, which can occur with our children with cerebral palsy together, have an even higher incidence when the two are together of sleep difficulties. I already mentioned very briefly, but we know that epilepsy really fragments sleep, disrupts sleep, particularly when it's not controlled, of course, and when it happens at nighttime, nocturnal seizures. Visual impairment, again, one of the most common things is getting the days and nights mixed up because you don't get those cues. You can just imagine the child that wants to sleep all day is awake at night. First of all, how difficult and challenging it is for families, but how hard it is then to function in school, in community activities. Everything we do in our daily life centers around a much more typical schedule of being awake, participating during the day, and sleeping at night. For our children who have GMFCS levels, particularly 4 and 5, with significant motor impairments, we know it's very hard for those children to change positions. I know how often I change positions at night. When I'm falling asleep, I start on one side, and we all do. We usually then go to your back, other side, whatever. We don't necessarily wake up and say, I'm doing those things. They happen naturally in our sleep. But for children who can't do that on their own, they often are waking up because they're uncomfortable and they need somebody to assist in helping reposition them. Tone, spasticity can lead to pain. All of those in each individually can also lead to sleep challenges. And then GERD. GERD is reflux, gastroesophageal reflux disease. And particularly in our children who are nonverbal. For our children and family, children who are nonverbal, they can't complain, I have discomfort in my chest, I have heartburn. The things that we as adults can complain of, or that kids who are verbal and have those abilities can. And then equipment. So many of our children have so much equipment. You think of, the splints they have to wear at night for stretching, post-surgery. Each time you have to put something on and off, it can disrupt sleep. So really, why are they more common? Well, there's altered perceptions of environmental cues. We know that we tend to have, for many people, different cultures have, vary a little bit, but a large meal perhaps at lunchtime, a large large meal perhaps at supper time, maybe a snack before bed, but then we aren't usually having a big, heavy meal before we go to bed. But for children who are on tube feeds, where somebody is at, particularly 24-hour feeds or feeds throughout the night, where somebody is actually coming in, flushing, connecting, disconnecting, those are all things setting up a child for waking up. Also, as I mentioned around the children with visual impairment, the perceptions of lightness and darkness. You'll hear a little bit later how actually things happen naturally in our bodies when it starts to get dark at night, where our brains with input from our eyes and light help produce melatonin. So we're going to come back and hear a little bit more about that later. And that's the melatonin, as you'll hear, is actually a hormone that is released naturally in our bodies. And it is hypothesized that in some children or teenagers, that their bodies aren't producing enough melatonin, or they're producing it at different times. So melatonin induces you or starts you to start getting sleepy. But if it's happening throughout the day, then you're going to want to nod off during the day. And maybe if you've napped a lot during the day, then you're not ready to, have a full night's sleep. There is upper airway obstruction. Those are more organic sleep structural problems that can lead to sleep difficulties. And then there's medication effects. As parents and family members too well how many medications some children actually are on. And there are some medications, people tend to think of maybe the ADHD medications for attention deficit hyperactivity disorder. They have a side effect, they can keep you awake. But there's many other medications that also can disrupt sleep. Prednisone, for instance. And some of our children who have neuromuscular conditions can be on some of those medications. Even some of the seizure epilepsy medications, lamotrigine, is one example that some children may be on that also is known to have side effects of making it difficult to fall asleep. And then for our children who may have some cognitive delays, intellectual delays, learning challenges, that teaching good sleep habits, even for your typically developing children, can be quite challenging sometimes. But even more challenging when you don't have the ability to negotiate as easily. This was a study that came out in 2021 in a journal called Sleep Medicine, a highly respected journal. They actually looked at gross motor function impairment, cerebral palsy, and sleeping issues in both children and their caregivers. They had a sample of 87 families, and they wanted to look at that relationship. And they found that gross motor function, and I don't think this would surprise anybody there, but I want you to know, anybody here in this room, but that the literature actually confirms what you've probably known all along, that gross motor function does correlate with difficulties both falling asleep and staying asleep. And what they also found is that so many of the children in the study needed support nocturnal throughout the night. So they actually needed the family to come in. 52% had a minimum of one sleep disturbance. Many more had more. 45% of parents actually had to come in to intervene to help the child go back to sleep. And 62% of the parents in this particular study said they themselves, whether the child had a good night or a more disruptive night, they themselves were having sleep difficulties. This is a bit of an older study that came out in 2018 and looked at the prevalence of sleep problems in children with cerebral palsy. They had 150 children, and they used a sleep disturbance scale. And they found that 44% of children had more than one sleep issue. So, it's nice when everything is just a nice little checkbox and you just have my child has one sleep difficulty, maybe just difficulty falling asleep. But we know in so many cases it can be a combination, difficulty falling asleep, difficulty staying asleep, or maybe fall asleep easily, but then wake up at 4 o'clock and are ready, in the morning to start your day, or children who spread their sleep. They may have enough sleep if you look at a 24-hour period, but they're chunking it throughout the day. So how do you, stay awake for school, or stay awake for a, special family event? So you can just imagine that there are many kinds of sleep difficulties. Again, I think for most of you in this room, to no surprise, pain in this particular study was the strongest predictor of abnormal sleep or sleep difficulties. So how do we manage them? You always have to be thinking about the other medical developmental challenges that coexist. Pain is number one, and we saw that in other studies. Spasticity, our children can get spasms. Spasms can be painful. And then reflux. Again, I really believe that reflux is underdiagnosed in our population of kids, particularly when they're nonverbal. And we'll talk about some of the strategies maybe you can use with your pediatrician or a family physician if you think that might be the case. If the child truly is suspected of having sleep disordered breathing, a physical sleep difficulty, then that's when we need to make sure we're linking with our respirologist. For me, it's a colleague, or subspecialist. And then also managing expectations. I sometimes come across families who, at the end of the day, by the time supper time is cleaned up, you're exhausted. And even though your child, sometimes children might be teenagers, but they have, cognitive learning delays that actually perhaps they're functioning at a lower age, and they think maybe they need to go to sleep at more according to their developmental age. But the important thing is to remember, physiologically, when it comes to hormones, those children actually are teenagers, and they're like a typically developing teenager. They are really waking and falling asleep more in line what other teenagers would be doing. When the child is having difficulty just falling asleep, one of the things again is to think about reflux, because some children are totally fine, smiling, happy. The minute you put them down flat, that's when, if you think for those who may have had, even when you're pregnant sometimes, you can have problems with reflux, heartburn, and you get that uncomfortable sensation, and that's what happens to our kids as well. If you're thinking, if the most common problem presenting is nighttime awakenings, then we have to think about spasms, pain, inability to move, and then needing help with that. And then feeding. I mentioned how disruptive feeding tubes can be, disconnecting, connecting, or having that fullness feeling all through the night. Now, many children and youth, when a G-tube or a GJ tube is first inserted, they often start with very slow, continuous feeds. But as that tolerance improves, what you want to do is move to bolus feeds, which can be more consistent with mealtime when it's safe. But also, it really does often help improve night sleep as well. So how do we start? So if you are going to your physician or care provider with sleep difficulties, it's good to actually come with equipped, having the information to make the most out of that first appointment. So if you can keep any kind of a sleep diary, a sleep record, because if you come in exhausted, the first thing you're going to say is, I can't sleep, my child never sleeps, we're all exhausted. And when you're exhausted, things always perhaps feel a little worse maybe than they really are, but it's also helpful if you can present your caregiver or the practitioner with a pattern, because then it helps to see where do you want to start with the interventions. because there's no magic pill that usually changes everything at once. You want to know, like as a physician, I want to know how long the problem has gone on for. Is it something that just started since they went back to school? So you're worrying that it might be, maybe it's related to bullying, or placement in the classroom, or the teacher, or the positioning. But if it's a long-standing problem, then that's also very different. You want to know what the routine is. I cannot emphasize how important a routine really is. So the child knows what to expect. That's actually comforting, as opposed to, one day, he or she is going into bed at 6 o'clock or 6:30 right after dinner because it's been up so early, he or she's been up so early, or staying up until 10 o'clock. And I know family life is challenging, particularly when you have other children who might be engaged in community activities, but when possible, one of the most important things you can do is trying to set up consistent routines and consistent schedules. You always want to know, or I want to know, when a family comes in, what they've tried in the past. Because what I have also found is that families, eventually maybe we start talking about a medication, and I might mention melatonin. And they go, oh no, I tried that, didn't work. But one of the things I found out is there actually are ways to use melatonin and ways not to use melatonin. So we'll come to that a little bit later as well. I want to make sure I'm ruling out any medical problems, and always behavioral intervention is first. Sometimes we move to medication and we need medication, but we use both of them together. We talked again about having consistent bedtimes, consistent wake-up times, nap times. I actually sometimes am surprised that just because a child has cerebral palsy or another disorder, challenge, that families think, well, then they need to still be napping. And it's not the case. If I have a cold or a flu, then I need to nap. Another child who is typically developing would also need to nap. But when the child is in good health, is feeling well, and they're at the age where they should have dropped their nap, just because they have cerebral palsy doesn't mean they have to keep napping. You want to make sure that there are no frightening TVs or stories. I actually had a family who, at mealtime, they actually did their best to have everybody kind of sit down at the table together. It was wonderful family time. But one of the things is Dad liked to have the news on because he was so busy in the day he didn't get to actually see what was going on. And it was kind of just on in the background. But you all know that news today is a pretty scary thing. And the kids were picking up on this. They may not have understood everything, but they saw some pretty graphic, horrible things on the TV. And when we actually got down to it, they were so worried that the house was going to go up in fire because they had seen all these fires on television. We know that having a dark, quiet environment is much more conducive to falling asleep. There are people who think, well, if I tire my child out, he'll fall asleep more easily, because I know when I'm exhausted. But doing physical activity just before you go to bed, you actually, it's almost like waking yourself up. Sorry, just need to get a little water. So it actually can have the opposite effect. Physical activity and recreational activity is really important for our kids and families, as you probably have heard so much for those who spent time at the conference. But just before bed is not when you want it. The other thing is people think, well, computer games or looking at doing a game on the tablet, they're actually sitting, so it's sedentary. But some of these games, the avatar is moving, it's very exciting, they get excited about it, they're moving their fingers or they're moving a switch, and it actually excites them and wakes them up as opposed to calming them down before sleep. And then the other important thing is always remember to put a child to bed awake. Because children, if they're going to wake up in the night, they need to learn to put themselves back to sleep. And that's why we want to teach them how to put themselves to sleep initially. This you will find in your slides. This is out of Dalhousie University, but it's actually a free online resource. You just have to Google it, and you can find lots of information there, things that help you keep sleep diaries, things that help you track activities so that you can relate it more to sleep. So when you have time, just Google it. There's lots of nice resources there, and they're all free, everything you can download. This is actually, was published in 2021. The Autism Treatment Network, again, it's for families who have children on the spectrum, but I found that the visuals, particularly when we have a child with a neurodevelopmental disorder or CP with a cognitive or intellectual delay, that sometimes having the cue is a lovely reminder of what's going to happen, so they know what to expect, especially if the children tend to be a little more anxious. So, and you can cut and paste. Again, this is free. You can just download it, and you can cut and paste and put them in whatever order you want. That is for, works for your family. But again, it's just that nice reminder about what is coming in the evening. Again, I had mentioned a bit earlier how important it is to make sure that the bedtime is realistic. Is it consistent? Review, think about things that we do every night. You have to break them down. Dinner, and then playtime, and then bath time. And then sleep associations. Now, sleep association is anything that happens to a child or a youth as he or she is falling asleep. So if you are having to walk your child over, if they're younger, hold them on your shoulder and you're walking up and down the hall until they fall asleep, and then you tiptoe and suddenly put that child in their bed. If they wake up in the middle of the night, they have learned that the way they fall asleep is by being on your shoulder, and we keep walking up and down the hall. So you may have to do that 3 or 4 times a night. So we would call an incorrect sleep association, because the child cannot reproduce it on their own if they were to wake up in the middle of the night. Things like cuddling, things like listening to music, even having the hall light on. Those are nice things you can set up in the environment as the child is falling asleep. But what is important is that when you finish and you say your final goodnight or your final hug, that the room is as it should be throughout the night. So you don't leave the light on, and then when you go to sleep 3 hours later, shut the light off, because if the child wakes up in the night, the environment is not the same. This worked before. Was that a correct sleep association or an incorrect sleep association? I think it's pretty clear it was an incorrect sleep association. You can also see it's a bit dated. Remember the days of bumpers in the bed, and we don't use those anymore. But definitely an incorrect sleep association. This was published in our own Academy Journal in 2015. They looked at 90 studies with children with a variety of developmental disorders. And again, I don't think this will surprise you that more than half of the families needed many strategies to help improve sleep difficulties. So let's start to talk then about medication. When we consider medication, when we've tried behavioral interventions and they're just not working. Sometimes a child has just been hospitalized because of orthopedic surgery or for another medical reason. And because they've been in hospital, they've been, had nurses coming in and out throughout the night, they suddenly come home and their sleep is very disrupted. So sometimes it's just a matter of putting the rules back in place. Sometimes families feel guilty. We've just been in hospital, so maybe I'll have him or bring her into my bed. So the thing to remember is when you've had those disruptions, which are part of life, the important thing is when you get back home to return to what you were doing before as quickly as possible. The other thing, remember that there are interactions with medications that sometimes just because medications are natural or from the health food store that they can't interact, and they can, and we'll talk about some of those. And again, important to have realistic expectations. So melatonin is the medication when I have to go to medication that I do use most frequently. It comes in several forms, short-acting, time release. We also use baclofen. Now, baclofen is used, many of our kids might be on it for spasticity management. But for our children who do have spasticity, it can be very helpful at night. Even if their spasticity is not that significant that they've needed it throughout the day, but sometimes a dose at night, if they seem to be waking up uncomfortable, that they could be having spasms, then it's worth a try. We use some of these other medications, clonazepam, clonidine, and zopiclone, imivane. In Canada, it's usually called imivane, but has different names in the States. And these are kind of the order of medications, again, depending on the age, so we'll talk about some of those. Again, always screen for, again, other medications for our teenagers. We need to make sure they aren't using additional medications, drugs, and alcohol, which also can interfere with sleep on their own, but also interfere with other medications they're on. And then some of our children, perhaps with really severe anxiety, could be on SSRIs, and sometimes those medications actually can lead to something called restless leg syndrome, which is the constant need to move as you're falling asleep, and that in itself can also disrupt sleep. So we have to remember that it's not sometimes as simple as just sleep. Melatonin produced by the part of our brain called the pineal gland. It helps regulate our sleep-wake cycles, and its release is influenced by the environment. Again, as it gets dark, our body's production starts to increase, and then as it gets light, our body's production slows down. And it's actually called the sleeping hormone. It helps induce sleep. This is a 2018 study that looked at 13 randomized controlled trials with melatonin and found that it was incredibly helpful in improving overall sleep time, but it really didn't make a difference for the night awakenings in the middle of the night, but no serious side effects. Again, most of the studies are really just short term, so we really, for the kids who've been on it for years and years, I actually never recommend keeping a child on it. It's not a lifer. What we usually do is try to use melatonin to establish a good pattern, keep that pattern for 2 to 3 months, and then we stop the melatonin. If the symptoms recur, then you go back on, and every month or two we're trying to take the child off. Melatonin should not be used, however. I think he's going to have a bad night tonight, so I'll give it. And then he's not on it, or she's not on it for several weeks, and then I think it's going to be a bad night again. Melatonin is meant to be used at the same time every night for several months, and then you can take the child off. Usually 30 minutes before the desired bedtime. Unlike if your child needs an antibiotic, and we look at weight and then we figure out how much melatonin the child needs, it's a bit less predictive or prescribed. We generally, if the child's under 25 kilos, you always start with the lowest dose. I go up to 6. If they're over 25 kilos, usually start with 3 and up to 10. If 10's not working, nothing's going to work, in my experience. And again, always trying to say this isn't for life. We're trying to get the child off. Now, clonidine occasionally is used, particularly in our children who have significant ADHD, hyperactivity symptoms, inattention symptoms, and it can be very helpful given at nighttime as well. This is a very old study. There's not a lot of studies with clonidine for sleep. There are a lot of individuals who go to the drugstore, go to Shoppers, and are looking for over-the-counter medications, antihistamines, just because they're so available. They really are not to be used for pediatric. You can have actually an opposite reaction sometimes. I once had a family who said, first time I'm taking my child on a long flight, so they gave them antihistamine to knock them out, but the child actually got buzzed and was very, very challenging for that very long flight. So just something to keep in mind. For our children who have periodic limb movement disorders, or some I alluded to earlier, we do use clonazepam. Clonazepam is sometimes used for seizure meds as a medication, but we use it in very tiny doses to assist with sleep. And when melatonin does not work for a child, I will go to a small dose of clonazepam. When your child has significant spasticity, like again our level GMFCS level 4s and 5s, just as I've talked about, again, try to make sure the comorbidities are treated. But then I often will just give, if we really think it's painful spasms, we start with baclofen. And if that really isn't helping and the child's in significant pain, occasion, we've had to go to a dose of gabapentin for pain. I don't use this, but occasionally I come across a child who's been referred, and perhaps it was an older practitioner. Somebody still had recommended chloral hydrate. The American Academy of Pediatrics in the 90s came out against it, but I put it up there because I still, once or twice a year will come across a child who somebody has suggested that they try it. Herbal supplements, untested. The American Academy of Sleep Medicine did, in pediatrics, did look at an adult study with chamomile, kava, tryptophan, and really no evidence that it did anything. And then this is our newest problem. With the legalization of cannabis, I have many, many families who are asking me about using it for sleep problems. Now, there is some lovely evidence that's starting to come out in very specific epilepsy disorders, but there actually is no good study that actually shows it works in sleep, and we know that it can also be harmful. So really important to keep a diary, behavior first interventions. It's not easy. We don't fix everything at night, in one night. The child that's been sleeping in a parent's bed for months or years, and suddenly they change their mind, is not going to suddenly be happy just going in the other room, sleeping in their own bed. So you have to do it more slowly. I think what we'll do is we'll finish there. There is a case. I know we did start late. We're a minute or two over. Do I have time to take one or two questions?
Absolutely, and
Yeah.
I think we probably don't need a mic. Well, I think we've got a microphone if we want it, but if you want to raise your hand, we can run the microphone over to you.
Hi.
Yeah.
It's so nice to see you, Brenda. Yeah. Yeah. So I would hope that eventually, if you're calling your family practitioner frequently enough and letting them know you've tried this, it's still not working, that they will work collaboratively. But I know that there are some people who just, physicians, I find more family physicians just because they don't have the same experience perhaps as a pediatrician. I think actually there are free websites, like, even the site I told you about out of Dalhousie. Again, it talks about behavior, but it also is, there are some references, evidence. You can take, these slides, you can take some of the evidence, the references. Please share it with your pediatricians, your family physicians as well. So, like, for instance, reflux. You can buy over-the-counter medication. It's quite harmless. Try it for a couple of nights. Did it make a difference, right? When you put the child down, did he or she stop screaming? That's wonderful evidence to then take back to say, we need to do something here. The other thing, melatonin is over-the-counter. Again, I really think this should be done, though, in collaboration with your physician. And if they're really not listening, then maybe it's time, you have another physician.
That was sort of my question to follow up. If your family physician isn't really knowledgeable about this and is struggling to work with you on this, who would a physiatrist be the person to talk to? Who is it that would help manage this for families?
Yeah, good question. And I find it's very geographical.
Yeah.
Like, in the States, there's such easy access to physical medicine and rehab physicians. In Canada, we do have a few that work in pediatrics. In Ottawa, again, it's very geographical. In Hamilton, there is, but it's largely developmental pediatricians. But child neurologists often are very, very comfortable in managing sleep challenges as well. And more and more often, we're graduating complex care physicians. Now, again, tends to be more in larger cities where there's children's hospitals or larger peds departments within a adult hospital. But I think it's just trying to get referred then to another specialist.
Any more questions? Did I see that? No? Yes? No? I've got so many questions about medications, but
Okay. I'm around. We can
I'll
talk.
keep them to myself.